Advanced Neurosciences Institute in beautiful Franklin, Tennessee is hosting this NeuroNexus event. I'm joined by Dr. Jonathan Cockwood of the Shapiro Center for Multiple Sclerosis and Dr. Samuel Hunter of Advanced Neurosciences Institute. I'm Dr. Daniel Cantor of the Florida Society of Neurology. People talk about shared decision making. To me, shared decision making means that we're not living in this world where decisions are made from on top, that the doctor is making the decision and telling the patients what to do. We used to call that paternalistic medicine. We're now in an era where the decisions are being made together, where it's the patient or the person with multiple sclerosis in the room, maybe their care partner, there's the doctor, there may also be the payer, the insurance company, and all together we're making a shared decision. We're trying to decide what's best for that person. What does shared decision making mean to you, Dr. Hunter?
Well, it means, first of all, it's informed decision making, that someone understands why we're doing something, why we recommend doing it. And I narrow down the choices because while there may be a lot of options, there are usually some best options. Mm-hmm. And there may not be a single option, but there is a common goal. So identifying that to the patient who's having to do that and their family in some cases, and then identifying what the risks and the benefits are of this choice. And I think we've entered an age for MS where there are a lot of issues to consider. Mm-hmm. And so it's important for people to understand that because the government has entered into an era where they almost overdo warnings and safety issues on medications. And you look at older medicines and people think they're very safe because they didn't do that and they haven't changed it and updated. And some of these older medicines are not safe at all. Some of the newer medicines are very safe, but they still have warnings that they put in big bold print and, about whether there's cancer, infection, pregnancy issues, and so forth. And those are important for people to understand, but many times they're not relevant, or when you consider them to what the clinical situation is, whether they have risks that are really real of further disability in the near future, that they understand how to weigh appropriately those risks. And certain risks that we're taking may buy you many years of freedom, for a very modest risk. And understanding that, and not just in terms of, you could get cancer. Well, anybody can get cancer. What is the risk of it? Anybody could get PML. What is the risk of that? What is the realistic, how big a roll of the dice am I taking with doing something for a risk, and how big a benefit am I likely to get?
Dr. Cockwood, aren't decisions just made by the doctor? Why do we call it shared decision making?
We don't call it shared decision making. When I first meet a patient, we spend, obviously, as many MS specialists do, a lot of time with our patients. When I first meet a patient, one of the first things I tell them is, look, I'm probably gonna make you a little crazy when it comes to talking about selecting disease-modifying therapies, because my approach to treatment selection is collaborative. That's the word I use rather than share. And pretty much what you said, Dr. Hunter, is that education is really important. I want that patient to understand what the risks and the potential benefits of the treatment are, but I also want that patient to understand what the risk of their disease is. So it's commonly, it's easy to understand. We see what we focus on, and as you've alluded to with FDA warnings and more focus on safety, which is appropriate, we're often so focused on the risk of a treatment that we're ignoring the risk of the disease. So one of the first things I tell them is, yes, I'm going to make you crazy. I'm not going to tell you what to do. I will, however, lead you to several treatments that I feel are a good match for you and your MS, maybe in terms of side effects or in terms of some of the research data we have on the treatments, but I'm not going to tell you what to do. I get this one from time to time. Some people won't accept that, and they'll, after listening to me ramble on for 10 minutes talking about all the side effects of 4 or 5 different drugs, they'll just go, well, which one would you tell your wife to take? And, that's easy. And I say, well, I would tell her to take this one, but she wouldn't, and that's what they do. And I explain, it's not because she's oppositional, well, maybe a little, but not really. It's because my wife's tolerance of risk is totally different than mine. I tell my patients, I ride a motorcycle. My tolerance of risk is higher than my wife's is. But I know that. I've known her for a long time. I know what her risk tolerance is, and I've just met the person in front of me. So the way I explain it is I will help you, guide you to the treatments, and my approach is to come at the treatment, what effectiveness do I want for the individual in front of me? Then from there, we drill down on things like safety, side effects, tolerability, the sort of burden of care on the patient, how often they have to get labs, what sort of risks they're taking, day-to-day side effects, all these things are important. And one thing I try to make very clear, because I don't want this in the room, I tell them, don't worry about what your insurance company says or that. Let's pick the treatment that is the best match for you, and we will then figure out how to get it for you. Now that's become more and more of a challenge. I think it's very, very important. Very important to educate patients about and have them involved in the decision making, in part because if they've been involved in that process, let's say they hit a rough spot or they get a side effect of a treatment, my feeling is they're a little bit more likely to sort of hang in there with something rather than cut bait and run, or maybe just stop treatment altogether. I think another important thing that I want to inform my patients about is, especially in this world of MS where there are many different opinions from MS experts about what treatment to use, or early treatment, aggressive treatments, early versus later. I like to make it very clear to my patients where I come from in terms of what my biases are, and put that on the table. And I tell them I am biased to using stronger treatments, more effective treatments early in the course of therapy. And that's important to know. I also inform them that you don't have to follow my bias, but here's kind of where I am. If I'm making recommendations, that's kind of my bias. And I inform that there are other perspectives of looking at these approaches to treatments as well. And sometimes patients get a little sort of nervous about things, and I always like to also explain to them, look, if you do something, if you decide to do something that I don't agree with, yet I don't think you're likely to cause yourself any harm by doing it, I'll let you know. I'll tell you, well, I don't agree, but sure. If you're doing something that I think, and the word I often use is really bonehead, meaning they're likely to harm themselves, I tell them, I'm going to give you one of these. Get in your face, wag a finger, say, you can do this, and I'll let you do it, but I don't agree, and I think you might come to some harm. I don't want to kick that patient to the curb. You're not doing what I want, go away. In fact, I want to keep that patient plugged in, because if they choose to do something, either come off treatment when I don't agree, or take a maybe lesser effective treatment than what I think they should be on, when there's a problem, I want to be there. And if you kick them to the curb and they go somewhere else, or worse yet, they don't follow with the neurologist at all, well, we've all seen patients coming back 5 years later with irreversible disability that perhaps we could have prevented.
It sounds like shared decision making isn't just about making decisions together, but also in sharing your reasons for the decisions that you're making. And that open dialogue between the doctor, the neurologist, and the patient together is what's going to help both of them come together and make the best decisions possible for that individual person in front of them. I want to thank you so much, Dr. Cockwood. I want to thank you, Dr. Hunter, and I want to thank Advanced Neurosciences Institute for hosting this NeuroNexus event.